progress. So rapidly improving major stroke, improving major stroke, or if there is a seizure, acute MI, post-MI pericarditis, CT with hemorrhage or related low attenuation change, or history of highly suggestive of subarachnoid hemorrhage, or pregnant or lactating female, platelet count less than 1 lakh, prothrombin time more than 15, and then somebody is on anticoagulants, we won't thrombolyze. If the BP is high, we won't thrombolyze. But these are relative contraindications. Don't go by this. And then the absolute contraindications are very few. If the BP is high, then reduce the blood pressure and go for thrombolysis. We'll discuss about it. And then there is any heparin usage within 48 hours, elevated APTT, head trauma, or stroke within 90 days, GIR, genitourinary hemorrhage within 21 days, major surgery, lumbar puncture, or any non-compressible arterial puncture like subclavian artery puncture within 7 days, generally we don't go for thrombolysis. So we have discussed trials up to 6 hours, and then what happens after that. And then when there is a wake up trial group, there is one trial called EPIT trial. In this, they have seen the perfusion diffusion mismatch, and then they have calculated the perfusion, the amount of the tissue based on the CT by correlating the CT, and then they have seen if there is a large ischemic penumbra, and then they have used alteplase. And again, this is a double-blind, placebo-controlled trial to determine whether alteplase administered 3 to 6 hours after the stroke onset decreases infarct growth in the patients with known perfusion diffusion mismatch patients. So this trial confirms the results of diffuse trial. We'll go to the diffuse trial. In this trial, if you thrombolyze select group of patients 3 to 6 hours based on your diffusion-perfusion mismatch, there is a decrease in the infarct growth, and then there is better clinical outcomes and better neurological outcome, and then better functional outcome in this trial. So we are discussing about tenecteplase versus alteplase before thrombectomy for ischemic stroke. This is a very important trial which got published in New England Journal of Medicine, that is Extend IA tenecteplase trial. In this trial, they found tenecteplase is non-inferior to alteplase. We'll go to that. And alteplase is a fibrinolytic, and the dose is 0.9 milligram per kg, 10% to give as a bolus, rest infusion over 1 hour. Watch for severe headache, drowsiness, and pupillary asymmetry, and monitor and maintain the blood pressure. Tenecteplase is more fibrin specific. Bolus dose 0.25 milligrams per kg is the dose. Contraindications for IV thrombolysis we already discussed. And what are the complications of IV thrombolysis? We need to explain this to the patient, and then you need to take the consent. What is the incidence of symptomatic ICH within 24 hours? And then you need to quote the trials in NINDS or UCAS trial, and control of hypertension. If the systolic target, keep the systolic target of 140 to 160, otherwise the hemorrhagic transformation or hemorrhage risk will be high, and reversal of fibrinolytic effect with a cryoprecipitate, or we have a 4-factor PCC now which is available. Antifibrinolytic agent tranexamic acid can be used. Additional cryo may be given if the serum fibrinogen levels are low, if there is any hemorrhage after your thrombolysis. So mechanical thrombectomy is required whenever there is ICA, large vessel occlusion like ICA, internal carotid artery, or middle cerebral artery, or vertebral artery, or basilar artery. And then sometimes you may see tandem lesions. You may see thrombus in the ICA, and you may see thrombus in the middle M1 segment of the middle cerebral artery. Whenever there are tandem lesions, you need to target both the lesions, but you need to give, when you put a stent, and then you need to give higher doses of antiplatelets, dual antiplatelets. Again, the risk of spontaneous or asymptomatic intracerebral hemorrhage risk will increase. So thrombectomy after 6 hours, we have discussed till now about thrombolysis or thrombectomy up to 6 hours. But is there any benefit of these patients doing thrombectomy in 6 to 24 hours after the stroke with a mismatch between deficit and infarct based on your CT perfusion assessment, diffusion perfusion mismatch, and then there is a wake-up trial group or late presenting strokes undergoing neurointervention with the TREVO system. There are different devices available to do thrombectomy. So we'll discuss in that. In the DAWN trial, they've used a TREVO system, and then they have taken the patients up to 24 hours in the Dawn trial. So in the diffuse 3 trial, thrombectomy for stroke at 6 to 16 hours with a selection of perfusion imaging. Again, they use CT perfusion or MR perfusion in diffuse 3 trial, and then they have taken patients up to 16 hours. To conclude, the endovascular therapy plus medical management results in lower rates of disability and improved 90-day functional outcomes on the MRS scoring system in comparison with the medical therapy alone in patients who have a large vessel occlusion and favorable prognostic perfusion imaging. So when they did endovascular therapy. So if you look at the results, the endovascular therapy results are much better when compared to the primary outcome, the secondary efficacy, the functional independence. If you look at the functional independence at 90 days with the endovascular therapy, which is 41 patients had a good functional outcome, and only 15% of the 15 patients had good functional independence at 90 days in the medical therapy. No doubt the endovascular therapy is superior even after 24 hours if you select your patients properly according to your Dawn and diffuse trials. In the Dawn trial, they have taken patients up to 24 hours. In the diffuse trial, they have taken patients up to 16 hours. If you look at the disease score or recanalizations, or if you look at the median infarct volume, or if you look at the reperfusion more than 90% in 24 hours, everything is better in a patient with who underwent endovascular therapy. At the same time, if you look at the parenchymal hematoma, it is slightly more in the endovascular therapy, but no statistical significance in the both trials. So coming to mechanical thrombectomy, what go for mechanical thrombectomy? When you do a CT angio, there's a large vessel occlusion, we go for mechanical thrombectomy with a stent retriever technique. And then the criteria is pre-stroke MRS is 0 to 1, positive occlusion of the internal carotid artery, M1 segment thrombosis, or vertebral artery, or basilar artery, or posterior cerebral artery. When there's a large vessel occlusion, age 18 or older, NHS score 6 or higher, aspect score 6 or higher, and the treatment can be initiated within 6 hours of the treatment, and mortality and recovery at the discharge at 6 months same as compared to the anterior circulated strokes. Even in posterior circulated strokes, the outcomes are slightly better in thrombectomy when compared to thrombolysis, and there is a decreased risk of hemorrhage when you go for mechanical thrombectomy. So as I told, you see large vessel occlusion, and then you select the patient properly, create a stroke corridor, shift the patient to the cath lab, and then whatever system you use to aspirate that thrombus. Before we were using penumbra aspiration devices. Now the later Trevo came. Now we are using more solitaire in our institute, solitaire stent retriever technique. This is the solitaire stent retriever, the clot retriever, and this is, I think it is a Stryker one. The two different companies, Stryker and then the Medtronics and Penumbra systems. They're different companies in the market, and then these are superior when compared to aspiration techniques. When you do, before we were using Penumbra aspiration systems, when you're doing this aspiration, when you're doing lysis and aspiration, these pieces may cause embolization, but this is a better technique. Stent retriever and clot retriever technique is a better system when there is an M1 segment thrombosis, so that we can do good recanalization. If you see, there's a cutoff of M1, and then after thrombectomy, we can see we can establish a good flow. And again, the key to prevent intracerebral hemorrhage is blood pressure control. In acute hypertensive response occurs, we know within 24 hours of acute stroke, there is a up to 82% of the patients presenting to the ED with acute stroke have systolic BP greater than 140 millimeters of mercury. Acute stroke impairs the autoregulation of the cerebral circulation, so that the blood flow in the ischemic area becomes passively dependent on the mean arterial pressures. So the current recommended goals for the BP in the acute ischemic stroke is less than, again, you have to divide the stroke management, hyperacute, acute, and chronic. So you should know where is your patient exactly fitting. Is it in hyperacute condition where you need to decrease the blood pressure with IV medications, and then before you start your IV thrombolysis, the blood pressure has to be less than 185 over 110. And after starting IV TPA, IV like thrombolysis, you have to maintain less than 180 over 105. So the mild to moderately elevated BP should not be routinely lowered. The indications for urgent BP lowering, we know hypertensive encephalopathy, myocardial ischemia, or congestive heart failure, or thrombolytic or anticoagulant given. So we can use labetalol, we can use nicardipine, or we can use IV enalapril, and then, but better to avoid NTG or SNP, which can cause cerebral vasodilatation. Your ICP will go up. So these are the better agents, labetalol and IV enalapril. These are the better agents. So what is the target for our blood glucose, and is there any evidence? The recent trial called SHINE trial, the sugar or stroke hyperglycemia network group. So in that, they compared the intensive glucose control and the liberal glucose control. But in this SHINE trial, they found better outcomes when you maintain the blood sugars between 140 to 180 milligrams per deciliter. And then we need to closely monitor to prevent hypoglycemia. Intensive insulin therapy or intensive glucose control is bad again because of the hypoglycemia in patients with acute ischemic stroke. So what is the etiology for stroke? So we were talking about stroke interventions and all. What is the etiology for stroke? Large vessel, large artery atherosclerosis, ICA, MCA, vertebral artery, basilar artery, cardioembolic. We know when there is atrial fibrillation, LV clot, visitations, PFO, patent foramen ovale, lacunar stroke, if somebody is poorly controlled diabetes or hypertension. Other rare causes, vertebral artery dissection, hypercoagulable states. So these patients will get a stroke. So when you get a stroke patient, young stroke patient, you need to do extensive workup, ANA profile, vasculitis profile, and then thrombophilia profile. And you need to extensively investigate why this patient had stroke at this young age. So CT angiogram or MRI angiogram, when you're doing stroke workup, generally we do MRI stroke protocol in our stroke clinical pathway. After 24 hours after thrombolysis, we do MR stroke protocol, and then you do ECG, 2D echo. Some people, if it is a cardioembolic stroke, then you might have to do transesophageal echocardiography. You need to look at the HbA1c, lipid profile, homocysteine levels, transesophageal echocardiography, Holter when etiology is not very clear, and you may require more extensive workup in patients with patients who are young and then had stroke. So you should know whenever you have these rare cases, and then if you see a different case in your clinical scenario, in your like during your ICU posting, then you need to publish. One of our neurophysicians became very popular with this publication, and a lot of like media people were behind him, and he attracted a lot of media. And he is one of our neurophysicians. He described a beauty parlor stroke. He had few cases like women showing the symptoms of beauty parlor stroke syndrome after a hair wash at the salon, and then when they hyperextend the neck when to wash the hair. And these people, because of these, if they have vertebral artery atherosclerosis, or they're developing strokes, and then sometimes vertebral artery dissection. So when they go to the parlor, when they do the neck massage, or when they do hair wash, and then he reported these cases, and then he became popular. So you should know the etiology why these patients are developing stroke. And then we know the treatment first is IV thrombolysis, and then, as I told, after vascular therapy, you have to go for the medical therapy, antiplatelets like aspirin, clopidogrel for secondary prevention, and then we need to start statins and anticoagulation whenever there is cardioembolic cause or dissection. We need to give long-term anticoagulation, and then we need to monitor anticoagulation. So airway is very, very important. You need to maintain the airway. You need to prevent the aspiration pneumonitis. You need to do the swallow test. Unless you do swallow test, proper swallow test, and then if you have a speech and language pathologist, a swallow and language pathologist in your hospital, involve him, and then do proper swallow evaluation, because a lot of these patients will have dysphagia, And then this dysphagia rehabilitation is very important. They have decreased oropharyngeal function, motor function. So there's a risk of aspiration, or if the airway is compromised, and then we need to intervene. And if there is a dysphagia, then we have to go for nasogastric feeding. And if the patient is on endotracheal tube to maintain the airway, so when to go for tracheostomy. Stroke related early tracheostomy versus prolonged orotracheal intubation in a neurocritical care trial, that is set point trial, which was published in 2013. And they have taken both the ischemic and hemorrhagic stroke patients in the neurointensive care unit. So early tracheostomy, they have done 1 to 3 days after intubation. Standard, they have done 7 to 14 days after intubation. Primary outcome, they have taken ICU length of stay. There is no difference in ICU length of stay. And early tracheostomy group had lesser use of sedatives and lower ICU mortality, but no major difference, but no difference in the ICU length of stay. But definitely the usage of sedatives are less, so that we can assess the neurological state. We can do better rehabilitation in these patients. We need a bigger trial about this, when to do tracheostomy. We have some evidence in the form of set point trial. So after that, after your acute care for the stroke patient, you need to provide a good physiotherapy. You need to mobilize these patients in the ICU. We have to involve physiatrists in the intensive care rounds, and then early mobilization is important, and then the prevention of pressure sores, DVT, and infections. So we discussed about the medical and vascular treatments, but is there any surgical treatment? When it comes to surgical treatment, malignant MCA infarcts, and then within 48 hours, if the ICP is going high, if they're becoming drowsy, and then you'll be using either mannitol or hypertonic saline. But when you do the scan, if they're drowsy, if there's a midline shift, then better to go for decompressive craniectomy. We have evidence in the form of decimal trial, Destiny 1, Destiny 2, and Hamlet trials. In all these trials, when they did decompressive craniectomy, within 48 hours, when they have taken a large flap of 12 centimeter diameter after, and then uroplasty, and the survival, the mortality rates are less when they did surgical management for stroke, that is malignant MCA infarct, going for decompressive craniectomy. And then they have seen mortality, less mortality, but obviously the morbidity was more in these patients, because more and more patients were surviving, and these patients were because of this the morbidity was increasing, and patients with vegetative state was increasing. But now I think we should do a better trial now, because we have better rehab hospitals, and then the outcomes may be better. Even the neurological outcomes may be better with the decompressive craniectomy. In Destiny 1 and Destiny 2, the difference is they have taken patients more than 65 years. In Destiny, so the brain can accommodate better than younger patients whenever there is swelling. So after your acute care, and then you need to shift the patient to the rehab hospital. We are fortunate to have one of the best rehabilitation hospitals. In this, we use exoskeleton, the robotic exoskeleton. For paraplegic patients, we use exoskeleton. And then we can make the patient walk, even the paraplegic patient, by using this exoskeleton. This is designed to support the relearning of the correct step pattern and weight shifts. And then we have for tracheostomy patients, and then more quadriplegic patients, and then patients who are bedridden for a long time. So we can use a robotic tilt table with a passive cyclic leg loading. And most of our tracheostomy patients will go on Erigo, and then we are seeing better results, and we are able to decannulate them faster, and then they recover faster, and then the DVT complications are less, and then they regain their bowel and bladder functions more quickly than other patients. So to summarize, stroke is a medical emergency. You need medical, vascular, and surgical treatments. Early detection and treatment is the key. And window for acute therapy is within 4.5 hours to 24 hours. Blood pressure and blood glucose should be optimized. Physiotherapy and antiplatelet statins key for the recovery and to prevent recurrence. Thank you so much.
Thank you, Dr. Subha. I think it's a wonderful, very crisp lecture. Actually, everything is neatly told by you. So I think it will be very much useful for our DNB students and residents. And any questions in the chat box, we can take it. Otherwise, I have few questions. So what is basically your that rehab centers? Can you just tell us the means protocol? Like, suppose a patient who is going to be discharged from the ICU with a tracheostomy. So, what is your rehab basically for those kind of patients?
So when we are discharging a stroke patient with a tracheostomy, like we see whether the patient is requiring any respiratory support. If the patient is on sometimes tracheostomy, BiPAP, or if the patient is too drowsy, the GCS is very poor, and then these patients generally they don't get the rehab requirement. We need to wait because these patients are risky to go to the rehab. If somebody is on tracheostomy and then they're opening eyes, and then sometimes there may be aphasic, they may not communicate, but then they're off respiratory support, then these patients we take them to the rehab, and then we admit them in the rehab, and then we have a respiratory therapist, physiatrist, and then we give holistic care for these patients, and then we decannulate them faster than the acute care hospitals, and then we see less number of infections because they're not in ICUs, they are in rehab single room facility, the less number of infections, and these patients will definitely get benefited with a good rehab unit.
Okay. And the second one is like the artificial intelligence in most of the stroke patient. So there are a lot of softwares actually what we are using currently in our center. So normally this MRI perfusion scan, which is a quick scan, and the automatically will get to know that which patients will require thrombolysis, and at a very quickest interval of time. What is your experience on that?
Yes, now the artificial intelligence is taking over, and then the better models are designed now based on our CT perfusion and MR perfusion, and we get immediately like we need not wait for the radiologist reporting. Otherwise, doing a CT perfusion image is very difficult. You need a proper technician in the night time, and then to do a CT perfusion this thing. So it is, yeah, based on your artificial intelligence, you will get the report, and then you will take a call about thrombolysis. But for doing CT perfusion image, you need one of the like trained technician, and it is not simple in the middle of the night, and then it is again time consuming. But if you if you overcome these difficulties, and then based on your AI algorithms, the reporting is easy, and then you can take a call about thrombectomy or thrombolysis even after 4.5 hours.
Yeah, thank you. So there are one or two questions in the chat box. So the one question is from Dr. Mayur. So your valuable input in patients with recurrent stroke. So what are the workups needed? This is one question.
So if the patient has a recurrent stroke, then we have to rule out any cardioembolic event, and then you have to look at the atherosclerosis, other major large vessel atherosclerosis, and then you need to do complete cardiac workup, including your Holter, your transesophageal echocardiography, and then and then you need to see whether this patient is had previous TIAs, and then we need to work risk factors. You need to evaluate for the risk factors, and then if the patient is young, then you have to do this vasculitis profile, thrombophilia profile, all these workups we have to do.
Yeah, so I remember a case actually where this patient, particularly with cardioembolic stroke, they throw recurrent stroke actually. Patient may be in AF. Sometimes they don't realize they came with a stroke, and you treat them. Then again, if the rhythm there is a problem, then they again go into the same stroke or stroke-like symptoms. So that is why in few of the cases actually we have instituted AICD kind of devices to control the arrhythmias, and that is also one of the management in such kind of patients. And Okay, and the second question is like malignant MCA syndrome. So the question is like any light on the management and your experience,
Yeah,
malignant MCA.
malignant MCA infarcts we see commonly, and then we see in younger age group people, if they have a MCA infarct, they deteriorate fast. And then malignant MCA infarct patient in ICU, if they're becoming drowsy and see the eye opening is not there, and then sometimes the right-sided MCA infarcts can cause ocular apraxia, the apraxia of the eyelid, and then they will have ptosis. Sometimes the eye opening is not there. You should see why there is no eye opening. Sometimes if the patient is drowsy, if they are not able to open eyes, it's progressively becoming drowsy, and these patients we need to repeat our imaging, and then if you see the midline shift, and then you should take a call immediately for like a decompressive cranectomy. And this decompressive cranectomy, and then they have seen the benefit when you do within 48 hours. Later, if they do after 48 hours, then the results are not very good. If you look at all the three trials, the Decimal, Hamlet, Destiny 1, Destiny 2 trials, they have done this within 48 hours, decompressive cranectomy. Again, who is doing decompressive cranectomy? Not a junior surgeon. If they don't take adequate flap, and then the results are not good. So they have to take proper 12 centimeter diameter flap. They have to do decompressive cranectomy. Then the results are good. So before decompressive cranectomy, you need to manage with your anti-edema measures. You can give either mannitol or hypertonic saline. There's no great evidence to say that hypertonic saline is superior, but whatever you give, you have to monitor. If you're giving mannitol, you have to monitor the serum osmolality or osmolar gap. You have to maintain 10 to 12. Or if you're using hypertonic saline, you have to maintain sodium levels of around 155. If somebody is in hypotension or already dehydrated, then you may not go for mannitol, you go for hypertonic saline. And then you need a multimodal monitoring in your neurocritical care to identify these patients early, and then to give proper medical, surgical, when to go for surgical treatment for the malignant MCA infarcts. And definitely nowadays with all these interventions, the mortality is less, but in a malignant MCA infarct, the mortality, in spite of decrease in mortality, there is a lot of morbidity, and these patients may go for tracheostomy, and then they stay in our hospital for a long time, and then they stay in the rehab for a long time. But we see nowadays we are seeing better results because of the good care, good neurointensive care, and then they are doing thrombectomies, and then we see less number of malignant MCA syndromes after thrombectomy and better rehabilitation facilities. Now the outcomes are better.
Yes, absolutely. So whatever you told, like the multimodal monitoring is very, very important, particularly in a patient of stroke and this neurosurgical patients who are having cerebral edema with signs of raised ICP. So multimodal monitoring practices should be instituted in any institution who have a facility. So what normally do your ICU has like what kind of monitoring your ICU has? Like, do you monitor all those newer modality like your something called as your cerebral microdialysis or the non-invasive, the ICP monitoring devices which are now coming into the market?
So we have the ICP monitoring system. We have the Codman catheter, but we do more for a patient with IVH, intraventricular hemorrhage, with intracerebral hemorrhage. We keep the intraventricular catheter, and then we monitor ICP. Nowadays, we use ultrasound optic nerve sheath diameter we use for monitoring the ICP. Or in our unit, we have a transcranial Doppler. And these people, they're doing transcranial Doppler even in stroke patients, and then they're looking at the flow, and then they're looking at the midline shift in the transcranial Doppler. And then we have a cerebral oximetry device, which is a very non-invasive thing to monitor the regional oximetry. But again, it should be validated in stroke. It is we don't know how to use it appropriately in these patients. And again, the Lycox catheter, that is a cerebral microdialysis catheter, came recently into the market, and then we had one demo session, but we have not acquired into our ICU. but shortly, I think we may get that into our ICU because of these neurocritical care programs and neuroanesthesia programs developing all over the country. And our hospital, we started the DNB neuroanesthesia, neurocritical care. So now we need to go for the multimodal monitoring for all these patients because you have a trained person even in the night time to monitor this, because otherwise if you're getting so many inputs,
So do we regularly monitor brain tissue saturation?
Brain tissue oxygenation, we are not monitoring. The catheters are very expensive, and then we don't have that.
Okay.
Any role of BIS monitoring over there?
Yeah, BIS monitoring, when you're giving sedation to these patients, because if the patients are restless, again, the ICP will go up. So when you're monitoring, like you have to maintain proper sedation scores, and then if the patient is on ventilator, then we monitor BIS scores. Otherwise, for awake patients, no.
And any experience on the newer monitoring, like near infrared spectroscopy or some kind of the what is called as the newer ICP monitoring tools? Like nowadays, a lot of centers, they are practicing putting this non-invasive probes, the magnetic resonance probe below the skull, actually to capture the fluctuations in the ICPs. Though we don't have those kind of experience, but possibly theoretically, there are a lot many described. So any such
yeah, theoretically yes, so we may get more information, but we don't have much experience with that. And then again, there is no great evidence that your ICP monitored care and the CT guided monitored care both are equally good. And then it's not that ICP monitored care is more superior over your CT guided therapy. So as and when required, there's a doubt, you need to repeat the CT and then you need to take a call on your CT. So if you have a good neurointensive care, and then if you monitor the very closely, that gives good results.
Yeah. And what I can trace upon here is the you can say the clinical monitoring. Clinical monitoring is one of the best parameter for the bedside intensivist, like pupillary size, any neurological deficit recent onset after the the stroke, which again warrant for immediate CT and again treat the patients. So the clinical tools can never replace whatever the monitoring devices we have. That is the reason a practice of good clinical skills at the bedside is very, very important, particularly checking the pupils and all the reflexes, the brainstem reflexes, particularly what we monitor normally. Those are also important. The other question is like the role of NIHS score in deciding the treatment. Like normally NIHS score is used for thrombolysis, but can it be a deciding factor for thrombolysis versus mechanical thrombectomy?
See, if the NIHS score is too less, if less than 3, then we may not thrombolyze. If the NIHS score is more than 3, up to 20, 21, we thrombolyze. And then if the NIHS score is very high, then the thrombolysis, IV thrombolysis may cause hemorrhage. So we can go for mechanical thrombectomy if the NIHS score is very high. If there's not only based on NIHS score, and then you look at the imaging, and then when there's a large vessel occlusion, we go for thrombectomy. But nowadays we are getting trials, even M2 segment thrombectomies. So we know the M1 segment thrombectomies, the outcomes are good. Even M2 segment thrombectomies, also the new trials, the outcomes are better even in M2 segment thrombectomy.
Yeah, Dr. Reddy, I have one question. So, do we monitor reverse jugular oximetry? This can help us to identify what is the venous oxygen saturation, and that can give us direct measure of perfusion of the brain.
No, we don't monitor, because again the venous return will be impaired, and then by putting these catheters, we don't monitor the venous jugular oximetry. But the role also in the multimodal neuro monitoring, when you're doing hyperventilation transiently to decrease the ICP, if you don't have any other monitor, then you can depend on the jugular oximetry.
Okay, there is one more question in the chat box. Can I take this question?
Yes, please.
Yeah, so this question is regarding what is the mortality percentage following decompressive craniectomy, and what is the percentage of vegetative life post decompressive craniectomy? Very theoretical question and very epidemiological question.
Yes. So if you look at the mortality in the malignant MCA infarcts, like the mortality is very high. If you look at the left left malignant MCA infarcts, the mortality is close to 50%. Right is slightly less. But when you do decompressive craniectomy, in all the trials, the found mortality is less. But again, the morbidity is more. And I don't know whether to say this a vegetative state or not. They're not in a vegetative state. They understand everything and they respond, but they're aphasic. They cannot express. So they sometimes they'll have global aphasia. So we may not call them as vegetative patients, but still the morbidity is very high. But nowadays, I think because of better facilities and all, that we are able to decrease the number of vegetative patients. But whatever said and done, when there is a malignant MCA infarct, the outcome is going to be very bad. There is going to be a lot of economic burden on the family. So countries like us, countries like India, can take this economic burden if he's the breadwinner, and then if they're spending a lot of money. It's a philosophical question whether to do decompressive craniectomy and prolong the life. And then again, countries like us, they don't know whether the decompressive craniectomy is really useful or not. It is debatable, and then they debate in all the conferences, but we don't know. But if he's a young patient, and then like we need to do everything according to the evidence, and then we if he is particular if they're young, we see better outcomes in these patients.
Yeah, so
There is one more.
for the exam guide, it is very important that they should read this Brain Trauma Foundation recent guideline. So it is one of the important questions which can be asked in the theory as well as in the practicals. And different signs like you have narrated beautifully, all the insular sign, the ribbon sign, and other things. So those are of a favorite topic of the examiner, and particularly the subarachnoid hemorrhage. So these are the areas which actually need a discussion, a separate class. But what are the trials you have enumerated? I think every trial should be read by heart, particularly in the questions which can become in the recent advances. Yeah, Akhilesh, you are asking something?
Yeah, there is one more question in the chat box, like, so what is the evidence of thrombectomy versus thrombolysis in pregnant and breastfeeding patients?
Yeah, it is a medication, but to save the mother, we should go for thrombolysis. It is a relative contraindication, not absolute. And going for mechanical thrombectomy, again, the risk of radiation when you take the patient to the cath lab. But when there's a large vessel occlusion, we need to save the mother and then take that, and we can go ahead with the mechanical thrombectomy. That radiation risk will be always there. And then we should cover the abdomen with these screens, and then we should go ahead.
Okay, I think we have covered most of the parts, and with the interest of time, I think we need to stop here. And if Swapnil is there, Swapnil, can you just make a concluding remark? And thank you for this wonderful lecture and discussion, Dr. Subha. Actually, this is a very eye-opener and one of the illustrative lectures we have. And definitely we like to have more and more such interactive sessions regarding neurocritical care from you. So, Swapnil, if you are there.
Yes, sir. Yes, sir. I'm here, sir.
Thank you, Dr. Reddy.
So-
Thank you very much. Indeed, it was a great pleasure to have you with us. Really. Thank you very much.
Yes, sir. Yes, sir. So once again, I will thank Dr. K. Subba Reddy, Dr. Gunadhar, Dr. Akhilesh for arranging such a wonderful platform for all the students, and particularly today's topic and interactive session. Again, thank you. I again thankful to Dr. K. Subba Reddy, and we'll look forward to continue this series, and we'll try to cover as much as possible the syllabus, and we'll try to make it repetition of all these topics whenever it's possible. So I request all of students to go ahead with the YouTube link which I have supported in the chat box, and you will get all the updates and all webinars on that YouTube link. Particularly, we are a little bit lagging. We'll cover it up. That is the thing I can only speak. Thank you very much once again.
Yeah,
Thank
thank you, Swapnil. Thank you, Swapnil. Thank you, Dr. Shiva. And hope to see you soon again.
Yes.
And it's a really wonderful session. Thank you, all the
Yes.
team delegates and all the panelists. Thank you
Yes.
from
Thank
our
you.
side.
Thank you.
you.
Thanks. Thanks.